Greetings all. This is the first conference to be organized by DAR Egypt. My topic today is going to be insulin therapy in patients who intend to fast during Ramadan. My agenda is going to cover the following topics. I'm going to rapidly review the available insulins and insulin regimens used in type 2 and type 1 diabetic patients. And then I'm going to rapidly go through the most recent risk stratification recommended by DAR in 2021. And then I'm going also to go rapidly through the points for pre-Ramadan education that has relevance to patients who are being treated with insulin. And then I'm going to remind you with the recommended modifications of insulin regimens in patients who intend to fast Ramadan. So starting with the first item in the agenda, which is the available insulins. So insulins can be classified into either basal insulins, bolus insulin, which may be interpreted into patients having basal oral or basal bolus or basal prandial or a premixed insulin. Starting with the first type of insulins, which is the basal insulins. As you can see here in this picture, we have the action profile for 5 so-called basal insulins, starting with the first one, which is the MBH. The MBH in the green light, as you can see here, this is the action profile. It has a half-life of around 4 hours. It has a distinct peak that starts 4 to 6 hours after injection, which increases the risk of having hypoglycemia for patients who use this as a basal insulin. And it has a duration that lasts for 12 to 16 hours, which makes it unsuitable for patients who require basal coverage for 24 hours. And then the second one, which was the Tamer. The Tamer had some improved characteristics, like if you can see here, the half-life is longer, 5 to 7 hours, with unfortunately a peak that increases the risk of hypoglycemia that occurs 17 to 14 hours, but it has a duration that lasts from 20 up to 24 hours. And then we had the insulin that constituted the standard of treatment for about 15 years, from the early 2000s until 2015. This is the insulin glargine 100. It had a half-life of 12 hours. Unfortunately, a small peak occurring 4 to 12 hours after injection and a duration of almost 24 hours. And then in 2015, we had the second or so-called third generation basal insulins, constituting first glargine 300 was a half-life of 18 hours, a duration of action of up to 36 hours. It is a peakless, which accounts actually for the benefits of using this insulin against glargine 100 with a reduced risk of overall hypoglycemia and nocturnal hypoglycemia and severe hypoglycemia. And the same goes for insulin degludec, which has the longest half-life of 25 hours and a duration of action that lasts up to 42 hours. It is also peakless, which accounts for the different profile with low overall hypoglycemia, low severe hypoglycemia, and low nocturnal hypoglycemia compared to glargine 100. And both those types of insulin is used once daily, whether you are treating type 1 or type 2 diabetes. And then we go for the short-acting or rapid-acting insulins. So first we had the so-called human regular insulin. The human regular insulin has a slow onset of 30 minutes. The peak comes more or less late, 2 to 4 hours after injection, and the duration is much prolonged with 5 to 8 hours action profile. And actually this accounts for the shortcomings of such type of insulin. So it has a small peak that does not produce adequate control of postprandial hyperglycemia, and this increased risk of the patient having hypoglycemia within 2 to 3 hours after injection, and that's why the patients who use this type of insulin has to snack 2 hours after injections. And for these shortcomings, they had to come up with a better insulin, and that's why we had the group that's called rapid-acting insulins, with a much rapid onset of action, only 5 to 15 minutes, and a much rapid peak occurring 45 to 75 minutes, and a much shorter duration of only 2 to 4 hours. And as you can see, for the action profile, it is much better because it goes up very rapidly, and so it produces a very good control of postprandial excursion, a better control of postprandial excursion with low or reduced risk of having hypoglycemia 2 to 3 hours after the injection. Although not physiologic, however, it is used in many patients with type 2 diabetic patients, and unfortunately, due to economic reasons, it may be used in patients who are type 1 diabetic patients. That I refer here to premixed insulins. For premixed insulins, we have this mix of 70% of NDH and 30% of either human regular insulin or rapid analog insulin. And as you can see here, this shows the difference between having a mix of analogs and a mix of human insulin. As you may expect, the benefit is going to be through having a rapid acting insulin analog in this mix. So we are going to have a much rapid onset of action and a much higher peak of action and a much shorter duration for the rapid component, decreasing risk of hypoglycemia 2 to 3 hours after the injection. And only a few years ago, we had this new type of premixed insulins. And here I refer to the mix of insulin diglodec as part versus bi-asp or bi-human insulin. And even if you compare the IDIG as part to a patient who is having a mix of analog insulins, you are going to see that IDIG as part definitely would produce a better basal insulin coverage. So it would nicely cover the 24 hours, and this makes it more suitable for patients who wish to use a premixed insulin once daily. So these were the types of insulin for the insulin regimens. We may use premixed insulins only once, and by premixed insulins, I'm referring to human regular insulin plus NDH, analog rapid insulin plus NDH, or insulin aspart plus diglodec. We may be used twice premixed insulin. I'm referring to the same types of mixes. Once premixed can be used in type 2 diabetic patients. Twice premixed also can be used in type 2 diabetic patients, and unfortunately, in some patients with type 1 diabetes who do not have access to better insulins or who have economic issues. For type 2 diabetic patients, we have these two regimens, the basal oral and the basal plus 1 Prandial. These are very commonly used in patients with type 2 diabetic patients. And finally, the basal bolus, the most physiologic and the most recommended, which can be used definitely in patients with type 1 diabetes and sometimes in patients with type 2 diabetes. Going through the risk stratification that was recommended by the DAR in 2021. As you can see here, we have multiple factors, some of which we may call non-modifiable. So we cannot modify the type of insulin or the type of diabetes or the duration of diabetes, the presence or absence of chronic complications, or the presence or absence of pregnancy. However, some other factors may be modified, like the type of insulin or the insulin regimen that I'm using, and if the patient is following self-monitoring blood glucose or not. Eventually, when we calculate the sum of all these risk factors, we are going to have a certain score that's going to classify the patient into either low risk, which may fast if he wishes, or a moderate risk, which he may fast with close follow-up, or maybe he would have a high risk, and in most of these patients, we should advise the patient against fasting. So the factors that have a direct relation to which type of insulin the patient is being treated with, as you can see here, if the patient is receiving multiple mixed injections, he's going to have 3-point score. If the patient is using basal bolus, which is much physiological and recommended, is going to have a slightly lower score. If the patient uses once premixed, is going to have a 2-point score. And if the patient is using once basal insulin or twice basal insulin, is going to have a 1.5. So actually this type or this factor in the risk stratification, if you meet the patient in the pre-Ramadan evaluation visit, and if you can change the insulin regimen of the patient from a regimen that takes a high score in the risk stratification to a regimen that has a much lower score in the patient regimen, you may actually change the classification of your patient from a patient of high risk or intermediate risk to a patient with intermediate or low risk, allowing a patient who wishes to fast to actually fast. Another very important point, which is the self-monitoring of blood glucose. Among the diabetic patients who essentially should receive self-monitoring of blood glucose are especially those who are being treated with insulin. So if the patient is indicated, and certainly all patients on insulin are indicated for self-monitoring of blood glucose, but he is not conducting self-monitoring of blood glucose, he is going to receive 2-point scores. If he is indicated, but he's conducting this suboptimally, he's going to have 1. But if you make the patient that is indicated to receive self-monitoring of blood glucose perform it as optimal, he's going to receive a 0 score accordingly. If you educate your patient about the importance of having self-monitoring since he is using insulin, and if you empower him and remind him and educate him about the importance of having self-monitoring and how to perform this, you may actually decrease 1 or 2 points in the risk score, again converting a patient who would be advised again in fasting into a patient who can be advised into fasting Ramadan as he wishes. Going to the point that has a relation to a patient who is being treated with insulin, the pre-Ramadan education. So actually the pre-Ramadan education has many values. Summarized here in these 4 points. It is going to produce a better glycemic control, better self-monitoring, better adjustments of the treatment, modification to adhere to the guidance, and finally to empower the patient to fast safely during Ramadan. The points that has a very high relevance for a patient who is being treated with insulin, or he receives insulin as part of his treatment, you have to educate him about when to break the fast, because as our religion tells us, a patient must not harm himself. So you have to educate the patient if the blood glucose goes below 70 milligrams per deciliter, he should break the fast. If the blood glucose goes above 300 milligrams per deciliter, he should break the fast. If the patient is having symptoms of hypoglycemia, or if the patient is suffering from acute illness, he should break the fast. And then for the self-monitoring, so this graph shows us when to ask for self-monitoring. So we have up to 7 points during the 24 hours that have a specific importance for a patient who is fasting Ramadan. So the 7 points are those before suhoor, morning, midday, mid-afternoon, before iftar, and 2 hours after iftar, and definitely at any point in time when the patient feels hypoglycemia. So for some patients, especially those who are using basal bolus, is going to require almost all the 7 points. But for some patients who, for example, who is just using a basal insulin once daily, is going to require only 3 essential points. For the 3 essential points, this means, or this refers to the point at midday, the point at before iftar, because this is where most hypoglycemia occur, and the point at 2 hours after iftar, because this is where the most hyperglycemia would occur. And finally, for the evidence-based recommendations by the DAR in 2021, and actually it reinforces the same guidelines or the same guidance that was provided in DAR 2016. So for a patient who has type 1 diabetes, so the modifications is going to be according to which type of insulin and which type of regimen he is going to use. So if you have a type 1 diabetic patient who is using a basal bolus, using analog insulins, for the basal component, this should be reduced by 30 to 40%, and it should be taken at iftar. For the rapid analog insulin, the dose at suhoor should be reduced by 30 to 50%. The pre-lunch dose should be skipped, and the dose at the morning, it should be taken at iftar. Initially, it would be the same as pre-Ramadan, and then you are going to titrate it according to the value of the 2 hours after iftar. If you have a type 1 diabetic patient who is being treated with human basal bolus but using human insulins, not an analog insulin, for the NBH, the morning dose of NBH is going to be taken the same at iftar. However, the second dose of the NBH should be reduced by 50% and should be taken at suhoor. For the regular insulin, the dose at at the morning is going to be taken the same at iftar, and the afternoon dose should be skipped, and the last dose should be reduced by 50%, and it should be taken before suhoor. In the unlikely event that you have a type 1 diabetic patient who is being treated with premixed insulin, either due to lack of availability of better choices or due to economic reasons, then you are going to shift the usual pre-Ramadan morning dose to iftar without any modification or reductions. And for the second dose, it should be reduced by 50%, and it should be taken at suhoor. For a patient with type 2 diabetic patient, a patient with type 2 diabetic patient may be receiving a basal insulin. For a basal insulin, if it is taken once daily, the dose should be reduced by 15 to 30%, and it should be taken at iftar. If a patient is taking basal insulin twice a day, and this may be used in patients who use the MBH, the Tamer, or rarely glargine as the basal insulin, then you are going to take the morning dose as usual at iftar, and the second dose should be reduced by 50% and to be taken at suhoor. If a patient with type 2 diabetic patients receiving Prandial insulin for, let's say, basal bolus, which means he usually receives 3 doses, so the morning dose is going to be the same without reduction, and is going to be taken at iftar, at lunchtime dose, and last dose should be reduced by 25 to 50% at suhoor. If a patient with type 2 diabetes is receiving once premixed, so it should be taken the same without any modification or reduction, and it should be taken at iftar. If a patient with type 2 diabetic patient, type 2 diabetes is receiving twice premixed, for the morning dose, it should remain the same, and it should be taken at iftar, and for the second dose, it should be reduced by 20 to 50%, and it should be taken at suhoor. Thank you for listening. Thank you for attending. I hope this presentation would be useful for you, and I hope that you succeed in delivering this better care to our patients. See you soon, and I wish you a happy Ramadan, inshallah. Thank you.